Welcome everybody. Welcome to another session of Medico Apps MCQ Live. I'm Dr. Abhishek, your mentor at Medico Apps, and this is a series of Medico Apps mentorship session which we are taking to help you build some core concepts and practice your previous year question. Every time a lot of students come back to me and said, sir, whatever you teach or anyone teaches in the theory class, we simply forget it. But if you have taught us in a form of MCQ, we remember it. So that is a very interesting thing which I kept hearing from my students, and so I said that okay, let me take a series of MCQ session till the exam. So this is that series of sessions which I'm taking. So every day I'll be taking 4 5 core questions from very important high yield topics, and if you know these topics in and out, definitely you will be able to much better in your examinations because it will stuck to your brain. So this is the seventh session for this particular series, and all these sessions are scheduled at around 4:30 in the evening, sometimes at around 1 o'clock, and so again. And tomorrow we have a session at 1 o'clock. So tomorrow it's not 4:30, it's 1 o'clock. So anyone who is joining us for the first time, this is the first MCQ live session which you are seeing. Just give this video a thumbs up and subscribe to our channel. We have already reached in a very short span of time 37,000 subscribers. Thank you so much. Just started a few years back, and we have 37,000 doctors who follow us regularly. Give this video a thumbs up. If you have any suggestions or any comments or any confusion about this whatever I'm going to discuss, please feel to comment. And if you like this session, don't forget to share it. One last announcement before we start taking the MCQs for today. Daily update on WhatsApp. Every day I will send WhatsApp updates to all my students. Generally, they will involve concept cards or short videos or quizzes, long master classes, these live sessions notifications. So if you are a part of that group, you will get live session notifications. A lot of free PDFs, and not they are not just free PDFs, they are compilation. Very high topics are compiled into a 4 page, 5 page PDF, which you will find useful. So if you want to join, just go to medicoapps.org/groups. You can join any group based on which you are. So if you are a first year student, you can join a first year group. If you are a second year student, you can join a second year's group, so on and so forth. And if you join the right group, you will keep getting the content of that particular profession year only. So hope all to see you on our WhatsApp group. This is an admin post group only, which means that only I will be posting it, nobody else will be posting it. So it will not be you will not be disturbed by anyone posting random comments, only high quality updates from my end. So hope to see you all of you on the groups. This is the first question of today. Which of the following pathway does not take place in brain? And your options are glycogen synthesis, HMP shunt, fatty acid synthesis, or all of the above. So which of these pathways do not take place in brain? So if you know the correct answer, please write in the comment. I hope all of you know that there is a live chat section where you can put in your comment. So your question is, which of the following pathway does not take place in brain? Okay. Options are glycogen synthesis, HMP shunt, fatty acid synthesis, or all of them. Okay. Yeah. Hi Manish. So I've read it. I have tried to keep most of these sessions after 4 p.m. only, but someday because I may be busy in the second half, so I don't want to miss this session. That's why we have kept it at 4 o'clock. So let's start the discussion on this particular question. So this question is revolving around metabolic effect of insulin on brain. So the first thing you have to remember is, can anyone tell me that glucose in brain is taken up by which receptors? There is a there are multiple GLUT receptors. So which GLUT receptor is responsible for uptake of insulin in the brain? So remember, uptake of insulin mediated uptake in brain. So glucose is taken by GLUT3 receptors. Okay. And what is the characteristic feature of these GLUT3 receptors? These GLUT3 receptors have the highest affinity for glucose. Understood? So that is why even when the entire body may be starving for glucose, brain will take up the glucose. this is a very, very important high yield point. In brain, the glucose is taken up by blood-3 receptors. Another very important point on the same, which has been asked several times in the examination, is brain also have blood-1 receptors. And this primarily before the development of blood-brain barrier, brain primarily will have blood-1, but after the development of blood-brain barrier, it will be substituted by blood-3. Is it clear? So what happens? The moment with the blood through blood-3 receptors, glucose is taken up by the cell, and what does the cells do? The brain cells do. It will immediately convert this glucose into glucose 6-phosphate. This is the first step. Any energy-rich molecule which enters into any cell, it will be phosphorylated. Why it is phosphorylated? Can you tell me? So we know that cell membrane can allow only non-polar molecules to enter and exit. Polar molecules will need channels. Is it clear? So this glucose is non-polar. So this glucose has entered the cell. Now the cell does not want to leave it, let it go. The cell does not want to let it go. So what it will do? It will add a phosphate. So now this glucose 6-phosphate is polar, so it cannot exit the brain cells. And this is for the entire cell, any energy. Even fructose enters, brain will convert it into fructose 6-phosphate. If galactose enters, brain will convert it into galactose phosphate. So always remember this concept. Okay. So glucose is uptaken by blood-3 receptors and immediately converted to glucose 6-phosphate. A very important point. A very, very important point. Remember, brain constitutes only 2% of the body weight. Okay. But can you guess how much glucose does it use? Out of the entire consumption, it almost use 20% of the body glucose. Is it clear? So what happens to this glucose 6-phosphate? This glucose 6-phosphate in brain will undergo only and only one cycle, that is glycolysis. And for the Krebs cycle, only to produce energy. Now, this is a very, very stark contrast, because if you see liver, this glucose 6-phosphate can go into fatty acid synthesis. This glucose 6-phosphate can go into glycogen synthesis. Okay. In still other cells, it may undergo HMP shunt. Okay. So this glucose 6-phosphate can undergo into a lot of different metabolic pathways. But in brain, nothing doing, only and only energy production. So this glucose 6-phosphate will undergo glycolysis and Krebs cycle. Is it clear, everybody, or not? Is this point clear to all of you or not? So when I look at this question, which of the following pathway does not take place in brain? So glycogen synthesis, no, it does not take place in brain. HMP shunt, no, it does not take place in brain. Fatty acid synthesis, no, it does not take place in brain. So all of the above will be the correct answer. Give me a thumbs up if every one of you have understood this. If all of you have understood this, just give me a thumbs up. Very, very interesting concept, that in brain only and only glycolysis and Krebs cycle to produce energy will be there. Let's look at the next question for today. And this question again is a very, very high topic. Which of the following variant of PCR can amplify a small amount of target DNA in a sample contained with other DNA? And your options are arbitrarily primed PCR, multiplex PCR, nested PCR, or real-time PCR. So these are your options. If you can see the live, just write the answer. If you know the answer, if you have a guesswork, you can write the answer. Okay. I hope all of you can see the live chat actually. So which of the following variant of PCR can amplify small amounts of target DNA in a sample contained with DNA? Okay. Now, PCR is a very, very important topic, but now they have stopped asking PCR. They have completely stopped asking PCR. So Chaitanya says D, Dilip says Chaitanya says C, Dilip says C. So we will see. Okay, I'll just explain the answer first, concept first, and then we will come to the answer. So remember, PCR is a very, very important topic. But to make your life miserable, what they will do, they will ask only on the variants of PCR, and this they have been doing for the past 2 3 years. So first of all, what is PCR? Also called as polymerase chain reaction. So remember, it is a amplification technique. Okay, it is an amplification technique. What do I mean by amplification technique? Suppose there is a small amount of DNA, very small amount of DNA, but it is very difficult to detect that amount of DNA. So you amplify it, which means if the DNA is there, you increase the amount of the same DNA. For example, I'll give you, suppose a patient comes to me and I have to test him for a viral DNA, that is the person affected with that particular virus or not, but the quantity of virus in his body may be very less. So what we need to do is, if that virus is there, there should be a technique which amplifies the amount of virus in that particular in his body in the sample, so that that viral DNA amount is increased and we are able to detect it. So this is PCR. So we know about the basic PCR. Let's talk about the amplifier, the variants. The most important variant of PCR by far is what we call as the reverse transcriptase PCR, okay, also called as RT-PCR. Now, COVID has made this RT-PCR a household name. We know that the normal PCR only detects or only amplifies DNA. So, what in this we are doing is, for RNA viruses or RNA material to be amplified, first by using the enzyme reverse transcriptase, we create a cDNA, and this cDNA we amplify, or copy DNA we amplify, you know uh, using our conventional polymerase chain technique. And so this is the first what you call modifications, and COVID is a RNA virus which we are able to kind of detect using this RT-PCR. Let's look at some other modifications. The second modification is called as real-time PCR, also called as homogeneous PCR, also called as kinetic PCR. What is this homogeneous or real-time PCR? So in PCR, we are just amplifying. In the basic PCR, we are amplifying, but we are never measuring, in terms of how much was the initial quantity of the DNA or the RNA. Okay, but in this case, using certain what you call quantification methods like dyes or probes, okay, we are able to even in real time know what is the initial viral load. For example, in the first case only, I was saying that I want to detect if the viral DNA is there or not. So let's say the patient, I have started him on medicines and he comes after 3 months. I want to know that whatever medicine I have given, is the viral load come down or is it the viral load increasing? So that, for that we need quantitative assessment of the DNA present. So that is what is real-time PCR or homogeneous or kinetic PCR. Let's look at the next modification. This is called as the nested PCR. What is nested PCR? Suppose you go onto a crime scene. You go to a crime scene and there is a victim blood is all around. But is it not possible that in that victim blood there may be some DNA amount of the assailant also, or the murderer also? There is possibility. Okay, so what I'm saying is, there is the total amount of DNA is more, but the target DNA which we want to amplify is very less. In that case, what we use is something called as nested PCR, which means, and it's very simple. First, we amplify using outer primers, okay, and then we amplify using. So we use multiple set of primers, okay, to amplify the target DNA. Nested PCR. So when the total DNA is more, but the target DNA is less, okay, in that case we use nested PCR. That's what we have. Next is multiplex PCR. What is multiplex PCR? We have all gone to multiplex movie theaters. What is multiplex PCR? Multiplex PCR. So in a multiplex movie theater, what is it? You have multiple movies screening at the same time. Movies, some English movie, some Kannada movie, some Hindi movie in the same. So in a normal PCR, we amplify only one set of sequences or target DNA. But if you want to, amplify multiple DNA segments in the same PCR cycle, then that is called as multiplex PCR. Is it clear, everybody? The last is called as arbitrary primed PCR. Now, let me give you an example. Suppose I want to know if a particular chemical has certain carcinogenic effect on, let's say, grasshopper. If a certain particular chemical has some carcinogenic effect on a grasshopper. But here the problem is, I don't know what kind of changes it will do in the DNA. So in that case, what we do? We cannot design a primer because we don't know what will be the change. So in that case, we use something called as arbitrary prime PCR. So these are basically short primer segments, random primer segments, and these are primarily, as you know, used for what you call mostly for research purposes because they will amplify anonymous DNA segments. Okay, and this is mostly for research. When we don't know what we are looking for, then we go for an arbitrary primed PCR or randomly primed PCR. Okay, is this clear? So with this, now you know small amount of DNA contaminated with other DNA. The correct answer will be nested PCR. That is given by both Chaitanya and Dilip. Both of you are correct. Is it clear, all of you? Let's look at this question. Again, this was asked in your NEET PG. Which of the following has no role in management of diabetic ketoacidosis? Which of the following has, again, diabetic ketoacidosis, super important. Okay. Which of the following has no role in diabetic ketoacidosis? Anyone? Write in the comment the correct answer. So Chaitanya is saying D, antibiotics does not have a role. Dilip, anyone else wants to answer this question? Very important, very conceptual question. Which of the following has no role in management of diabetic ketoacidosis patient? Okay. So before I take you to the answer, let me take you to some very important theory. So when we talk about diabetic ketoacidosis, can anyone write, is it more common in type 1 or is it more common in type 2? Because we have something called as hyperglycemic hyperosmolar coma. So DK, can anyone write, is it more common in type 1 or type 2? Chaitanya is saying type 2. So DK is more common in your type 1 patient, whereas hyperglycemic hyperosmolar coma is more common in your type 2 patient. Okay, will you be able to remember? Also, it has much lesser mortality. Okay, and mortality here will depend on age. As the age of the patient increases, actually DK will have mortality increase. Okay, and in general, DK will have lower mortality as compared to diabetic hyperosmolar. Okay, here is it clear? So if the age is less than 40, you will have mortality less than 5%, and if the age is more than 40, mortality goes as high as 20%. First, is this clear? Now let's look at the pathogenesis of diabetic ketoacidosis. There you will have, so there is a diabetic patient, okay, and how does decay happens? Okay, so there is some metabolic trigger. Okay, we'll talk about this metabolic trigger, but all these metabolic trigger, what they do is they either increase the energy requirement of the body or also increase the insulin requirement of the body. Okay. So let's talk about this metabolic trigger which will increase the energy requirement or insulin requirement. So let's, very important, infections. Okay. So a normal diabetic type 1 patient, there is something happening which will either increase the energy requirement or the insulin requirement. Any acute illness. Okay. What are the acute illness we know of? Any MI, stroke, surgery, all these are very important. Also, not very uncommon is poor compliance, because this type 1 patients, many times they are very young, so poor compliance. Even insulin pump malfunction has been documented. Okay, so each of these you can see very easily what they are doing. They are increasing the energy requirement. So what will this cause? This will cause hyperglycemia. Okay, what will this hyperglycemia do? It will cause osmotic diuresis, and this will lead to fluid shift and dehydration. Any doubt in this? Let's look at another thing which will happen. So there will be increase in the ketone bodies because there is no glucose inside the cell, so it will start producing ketone, and this will lead to acidosis. Okay? And what will and this fluid or dehydration will also change electrolyte disbalance. Okay, so there will be change in the electrolyte balance. And what both of these are going to do? These are both either going to damage the blood-brain barrier, okay, and cause encephalopathy. So why I am telling you through the entire pathogenesis is you will realize without treating infection, and many of these cases the trigger factor is infection. Okay, so without treating infection, there is no chance you will be able to manage diabetic ketoacidosis. Okay, because one of the options was antibiotic. So how do this patient present? If we talk about the clinical presentation, so they will present with something like nausea, vomiting. All these ketone bodies, all these ketone bodies which are produced, okay, all these ketone bodies, they are ketogenic. They are, they trigger the vomiting and they cause nausea, vomiting. Another very important thing is they will have lots of abdominal pain. Okay, first they will have polyuria, okay, and then in later stages when the kidney starts getting affected, then they may have oligouria, and obviously symptoms of stupor, coma, encephalopathy will be there. One very interesting thing is there will be something called as acidotic breathing, also called as kusumal breathing. What is kusumal breathing? So we know, let's look at this equation. H2O plus CO2 will plus HCO3. So in this case, there is acidosis. So there is an increase in the hydrogen ion. So what will this excess hydrogen ion do? It will combine with bicarbonate and increase the production of carbon dioxide. And this carbon dioxide will lead to hyperventilation. Okay. So this is what is called as acidotic hyperventilation, which is seen in your diabetic patients. Okay. So now let's look at how do we manage it. Okay. So let's look at how do we manage these uh, patients. Okay. So the management, basically, there are multiple components of this management. The first and the most important thing is fluid management. Now, here you have to remember that the moment you start treating it, when the patient will come, there will be increase in the potassium level because all the potassium from inside the cell has been coming into the extracellular in the blood. But the moment you start with treating the patient, all this potassium may go inside. But when you are treating, the potassium's level will generally be high. Okay, so that is why one thing you have to remember, and this is very very important, ringer lactate is contraindicated kind of. You never use ringer lactate in diabetic ketoacidosis. What is the fluid of choice in diabetic ketoacidosis? You will use normal saline. Very very important. Normal saline is the fluid of choice for management of diabetic ketoacidosis patient. Okay. So how do you do it? Initially, you will do a fast correction. So it is like 1 liter per hour, and then you will reduce it to around half a liter or 400 ml per hour. Okay. So this is the fluid management. You will have to have a very very close watch on the sodium and potassium level because the patient sodium may increase. Initially, when they are presenting, the sodium will be low because of dilutional hyponatremia. But as you start treating them, the sodium level may increase. So if the sodium level increases, then you will start using N by 2. But you will never use ringer lactate in management of your diabetic ketoacidosis patient. Clear? Everybody clear? So the first is fluid management. Let's look at the second. So second is obviously insulin. Okay. So which insulin do you use? So remember, always remember we use regular insulin, and we first give a bolus of 0.1 unit per kg body weight. So for example, the person is 60 kg, so we will give you 6 unit as bolus, and after that it will be the same per 0.1 unit per kg, okay, per hour as an infusion. Okay, once the patient is stabilized, then you can shift to subcutaneous insulin. Any doubt here? Right. The third very very important is your electrolyte. Okay, so potassium levels have to be measured. And as I told you, the moment you start treating, so first the potassium level will be very, very high towards the higher range. The moment you start treating it, there can be fall. So you never give ringer lactate. What you do is you supplement it with potassium and you give it a 10 to 30 milliequivalent per hour. Is this clear? What about the acidosis component? Should we treat acidosis? Now, in diabetic ketoacidosis, remember only when we define diabetic ketoacidosis as 7.2 to 7.3, 7 to 7.25, and less than 7. Only when the pH is less than 7, which means only when it is a severe acidosis, then only you will treat this acidosis. Otherwise, you will not treat the acidosis component. It will automatically get corrected. Okay. And what do we use? We use soda bicarb. Okay. We use soda bicarb. Any doubt in this? And another, whatever the trigger may be, the most important trigger being infection. So antibiotics will have a role. Generally, the diabetic patient will be prone to infection. So anyways, we use antibiotics in management of DKA patients. Two, three very important things is, remember, we do not want a rapid correction of sugar. Can anyone tell me? Rapid sugar correction is not desirable. Why? Because if you rapidly correct the blood sugar, there may be very drastic shift in the fluid. I've told you, I've shown you the etiopathogenesis. A lot of the etiopathogenesis is around fluid shift. Okay, so if you rapidly correct it, again fluid shift will happen and cerebral edema and death will happen. Okay, so you do not want, generally you aim for a 10% fall every hour. You do not correct it rapidly. Okay, and what will happen if you try to correct the acidosis? If it is mild or moderate, what will happen is it will lead to metabolic alkalosis, dangerous metabolic alkalosis leading to tetany or laryngospasm or very, very rapid fall in the potassium. So these two overall parameters you have to remember. So now you can very well know that ringer lactate is never used. Either we use normal saline, and if the potassium level is getting high, then we use N/2. Sodium bicarb, yes, we use in cases of severe acidosis. Normal saline is the fluid of choice. Okay, so all these are super important questions. And antibiotics, yes, it has role. So it is asking no role in the management. So antibiotic cannot do. The correct answer is your A. Is everybody clear? Any doubt in this question? Any doubt in this question? Okay. So let's discuss the next question. Which of the following is a myeloma defining event? Okay. Which of the following is a myeloma defining event? Is it hypercalcemia? Is it, which is not a myeloma, sorry. Is it renal failure, anemia, or metabolic acidosis? Anyone? Put your answer. Anyone wants to answer this question? So let's learn about multiple myeloma and then we will try to answer this particular question. So let's talk about multiple myeloma. So what is multiple myeloma? Basically, if you see, multiple myeloma is a blood plasma cell dyskaryosis, and what happens there? There is an increased production of light chains of the antibody, specifically IgG. Most commonly, it will be IgG antibodies which are overproduced. Okay, so but in general, it's a blood cell dyskaryosis where there is a overproduction of the light chain. What causes? What are the etiological causes? So two important etiological causes is exposure to radiation, and the second one is exposure to petroleum. Exposure to petroleum product. So you will have a history of a woodworker or a farm worker who is exposed to the petroleum. What are the chromosomal changes? So chromosomal changes associated with multiple myeloma, very, very important question. So remember, it can be hyperploidy, It can be a deletion of 13q, which is the most common chromosomal change which is there. Then there can also be a deletion of 17p, and this is like makes it more aggressive. Okay, so it's one of the worst prognostic factor. Then there can be some translocation also, 1114, or translocation of 414, or translocation of 416. Okay, so all these are super important ones. Okay. In some cases there can be also one q amplification. So these are the chromosomal changes which you will see in the multiple myeloma. Okay, so what happens in multiple myeloma? Okay, so there is a myeloma cell proliferation. So what does happen? So basically this myeloma cell, this produces IL-6, IL-1, and macrophage inhibitory inflammatory protein 1 alpha. Okay, so this further will have three actions. Number one, it will lead to the activation of osteoblasts. And what does this osteoblasts do? So they will lead to bone reabsorption. So one of the clinical features which you are going to see is lytic lesions in various bone parts. This bone reabsorption can also present with pathological fracture, okay, or pain. The serum calcium values will be increasing, and remember, in this case, serum alkaline phosphatase is normal. Why? Because serum alkaline phosphatase is determined by osteoblasts and not osteoclasts. So this is a very, very important question for your examination. That serum alkaline phosphatase is normal in multiple myeloma. Many students will get it confused and get wrong. Another very important thing is this IL-6, has an autocrine effect. Autocrine effect, which means it will further increase the myeloma cell proliferation. So this is one. Now, because there is a myeloma cell proliferation, what is going to happen? All the other cell lines will be depleted. So there can be anemia. Again, a very important clinical manifestation. There can be neutropenia, very important, and then there will be thrombocytopenia. Okay. So the first set of symptoms is because of the increase in the osteoblast activity. The second set of symptom is because of the depression or decrease in the other cell lines like anemia, neutropenia, thrombocytopenia. Okay, and the last will be because of this immunoglobulin, this abnormal immunoglobulin which are being produced. So what will it do? So first is it will cause hyperviscosity, huge amount of immunoglobulin, so it will increase the viscosity of the blood almost 2 to 3 times the normal viscosity it will be there. So what will happen? Sluggish circulation will cause problems in your retinal circulation, in your brain circulation, even renal tubule ischemia. All those things will be there. Amyloidosis, okay, and obviously they can coat the platelet. The platelet is already less, thrombocytopenia is there. This abnormal immunoglobulin can float platelet, and then there can be bleeding because of bleeding manifestations. Okay, another, because of these abnormal immunoglobulins, you can have symptoms of cryoglobulinemia. Okay? Cryoglobulinemia. So these are the various presentation. What is the cause of death in a multiple myeloma patient? Remember, it is generally the pneumonia. So repeated, because a lot of these patients will have infections, chest infections, pneumonia. So that is the leading cause of death, and especially by the capsulated organisms like pneumonia. Okay, so pneumonia is the most common cause. So let's quickly look at the clinical features, how they will present, and based on that we can define the what you call diagnostic criteria. So clinical feature, the most common presenting feature is bone pain. Okay, remember this. This is the most common presenting feature, and obviously fracture, pathological fracture in vertebra can present with compressive myelopathy, and you can also have patient, when you take a history, they will give you hypercalcemia features like lethargy, fatigue, CHF, CKD, uremia features will be there. hyperviscosity symptoms, so headache will be there, dizziness, vertigo, even transient blindness or renal failure. All these can be there. So hyperviscosity, priapism can be there, okay, and pallor, bleeding manifestations, okay. So all these, and even because of amyloidosis, carpal tunnel syndrome can be there, okay. And cause of death is infections followed by renal failure. So there is a diagnostic criteria based on the clinical features and some findings which we will see. So what is the diagnostic criteria for multiple myeloma? So when we do a bone marrow examination, the clonal cells should be more than 10%. Okay, should be more than 10%. So there should be the marrow clonal cells should be more than 10%. Okay, or there's a mnemonic called as CRAB. So this should be there, and one of the multiple myeloma defining events should be there. So C stands for calcium. So hypercalcemia, which is defined as more than 11. Then renal failure, R is for renal, with symptoms of uremia, features of A is anemia, so hemoglobin less than 10, and B is for bone lesions. So lytic lesions, more than 2 lytic lesions, either demonstrated on X-ray, PT, PET, or CT, whatever. Okay. There are certain other multiple myeloma defining events. For example, if there is an what you called focal lesion of more than 5 mm lesion on MRI. Okay, so these are the multiple myeloma defining events, and if it is present, then you will have a strong case of multiple myeloma. Is it clear? So this is what. Okay. So this brings us to the end of today's session. And the correct answer, so we have seen the multiple myeloma defining events. So hypercalcemia is there, renal failure is there, anemia is there, and metabolic acidosis is not a part of that. So the correct answer will be D. Any doubt? So this brings us to the end of today's session. In general, whenever I talk to my students, one of the biggest thing they will talk about is revision, and that is why I keep talking about revision. Uh, and this is the biggest challenge. And when I talk to them, I realize that why revision is so much challenging, because the amount of information which you have to learn is huge. Revision also is very very boring. I mean, nobody wants to revise, and even if you take the hard work of revising, bring in the discipline of revising, you keep forgetting, because most of the things which you are revising is actually passive. So for that, what we have created is something called as Medico Apps concept card. What we have done is we have taken only the high information which you keep forgetting, and which you have to remember for the examination. Okay, and created images and flowcharts based out of this particular, information, and made it in more of a question answer kind of a thing. So if a flowchart is there, directly they will not show you the flowchart. In one image, some part will be shown. In the next image, some part will be there. So you will keep thinking, what will come next? What will come next? So this comes as a active learning. So this is Medico Apps Concept Card. I will urge you to go and have download the app. You can simply go to the Play Store, search for Medico Apps Concept Card, and you will find that. So this is end of session 7. Tomorrow is session 8 at 1 o'clock sharp. We will start it. Please give a thumbs up to this, like to this particular day. If you are new, subscribe, comment, share, and if you like these sessions, if you want more updates from me or my team, just subscribe to our daily WhatsApp update. It's very very simple. Go to medicalab.org/group, join the group, and best part is, WhatsApp gives you that freedom. If you don't like my update, you can simply exit it. But I promise you that whatever update will come into these groups will be super important, super valuable for you. With this, we've come to end of today's session. Tomorrow's session is at 1 o'clock. See you all, guys. Thank you so much for tuning in, and take care. Bye.